getting his leg into a figure 4, applying pressure onto his ASIS, and then gradually pushing down onto that. Hey everyone, this is Dr. Jonathan at Kalkstein Chiropractic, your Baltimore area chiropractor. And today again we have a special guest, Michael. Our team lead CEA, and video that you guys probably saw before this one is about gluteal tendinopathy that we did, and Michael was the subject in that. And while we were filming, we kind of just mentioned or found that he was pretty tight in his hips. And then I don't know if you want to share your story.
Yeah, so got tight hips. I grew up playing soccer.
Yes.
Through high school, a little bit into college, and then kind of dabbled in the running scene. Nothing too competitively, but just haven't done a whole lot in the way of, you know, multi-planar movements, I should say. So I'm just kind of doing squats and lunges and running. So a lot of linear movement patterns. I've noticed just on my occasional weekend yoga class that I'm very restricted in like pigeon pose, for example. And many people pointed out that I've got very tight hips, Dr. Jonathan being one of those people. So I'm hoping just to kind of get to the bottom of it and sort of figure out if there's any way to get some more movement in there.
Nice. Also, correct me if I'm wrong, you're doing the Baltimore half or full marathon?
Half marathon. I know, not as cool as the full, but I'm pretty excited.
Hey,
I'm pretty nervous as well.
Definitely more than I would do. 10K is my limit at this point, maybe down the road.
Still really good.
Thank you. But so before we kind of dive into what we normally diagnose these symptoms, well, usually it's some sort of impingement that when we do these tests, we'll show you in a second, that usually alludes to some sort of hip pathology. So there could be just a normal impingement of the tissues like labral, and then just the musculature that goes into that area. There's a lot of different areas or tissues that meet in this junction. The one that I want to talk with you guys today is called femoral acetabulum impingement, or FAI for short. So a lot of different words in that, and we're not going to look at this poster as to visually what we're talking about, so you guys can see and not just say, oh, you're just using big words, please stop talking. So first, the acetabulum is going to be this socket right here. So your hip is going to be a ball and socket hip joint. So your femoral head, which is this guy right here, should sit very comfortable into that socket right there. So sometimes people who have impingements can either be a cam or a pincer lesions. Those types of lesions are just a form of which tissues are being affected, and it's usually congenital, meaning you're born with it. So first, most commonly is going to be the cam lesion. And so cam lesions are generally where the head of the acetabulum is not shaped correctly. So if you can kind of see how that is like almost like a round head with like an hourglass neck, and that's a normal presentation. If we have a cam lesion, most of the time the femoral head is the one that's affected within a normal acetabulum. So everything inside here is nice and kosher, functions normally. However, when a cam, this bone is not shaped like this. It's either overgrowth of the head or affecting the neck too. So see how that's nice and round and like an hourglass there? If it's a cam, it's usually going to be like an egg shape, so it won't be fully cylinder and fit nice and well into that socket. It'll have a little bit misshaped, which in turn, when you're trying to do specifically flexion movements or internal rotation, that decreases the space in there, and people complain of hip pain. The second most common is called pincer lesions. Pincer lesions are more common in women and later on in the third decade. So that's going to be affecting more of the acetabulum rather than the head itself. So the acetabulum, there's different tissues, cartilaginous, not just the muscles itself, which can overgrowth and cause decreased space within that hip socket. So both are very common, and then even more common than one or the other, it's going to be a combination of the two, which is the most common that we see. How we see that and how it's presented into our office, Michael kind of just said most of the things that would be provocative: squats, any type of flexion of the hip with the internal rotation. So Michael's running a lot, he's getting ready for this half marathon, and overall he moves really well. But just to kind of conclude that it is an impingement, there's some tests that we can kind of roll in. So Michael, if you please can get on the table on your back, and we're gonna check both sides out. So cam and pincer lesions are generally presented bilaterally, but symptomatically it's going to be one side or unilaterally. So I think it's more so this hip, correct me if I'm wrong, or this one.
Yeah, I think
You're
it's
right.
more the right side.
Okay.
Yeah.
So there's one test called Faber's test, F-A-B-E-R, or figure 4, and this is just a generalized assessment to see if there's any impingement or hip pathology for that case. So getting his leg into a figure 4, applying pressure onto his ASIS, and then gradually pushing down onto that. And is that uncomfortable at all?
I'd say slightly.
Okay, and where would you point to that?
Like right up in this region.
Exactly. So that's going to be a lot of the location of area of pain is right in that front of the hip and a little bit high too. And then another thing that we can test is just how much mobility he has from the table to his knee, which generally is about like a fist and a half for most. He's pretty close there. So when he gets there on his own, actively, it's pretty good. Passively, when I try to get into a little bit more end range, that's when he feels that stretch and pinch. And so that doesn't really rule in a cam or a pincer lesion in itself. The next test will be more so indicative of that. So that was Faber's test. We are going to do Fadir's test now. So Fadir's test is just a little short name for the movements that we place his hip in. So F-A-D-I-R, meaning flexion. Bro, you are so tight. Like and little, like most people, it's a nice gradual glide. It gets caught like right there. So flexion, the A is going to be adduction, and then internal rotation of the hip. And he's getting to basically 90 before it gets a little tight. Generally, I want a little bit more give in that. And how does that feel?
It's a little pinchy.
Yeah. In the same location?
Yeah. Maybe a little bit more lateral.
Okay.
But same general region.
So that brings up another point that, like in the last video, gluteal tendinopathies, these tendons, write down which member tendons they were. I won't say it, you gotta look it up. But those can be also affected to his external rotator. So we're placing that hip into that position, so it doesn't like that as well. So he has kind of a combination of hip impingement as well as some tight glutes too. So that is going to be kind of a basic assessment into this area. How we treat that is going to be a combination of a lot of soft tissue work here with ART, active release technique, some fascial work where I can oscillate those junctional areas and help release the tension in there. And then other things like we have in the office, dry needling would be a really good one, and as well as laser therapy and then even shockwave therapy. So very powerful modalities that can definitely get really good results here. And just wanted to show you guys a presentation, the symptoms that a patient will come in with. Again, it's going to be people very active, either a lot of hip flexion, internal rotation, so runners, but also a lot of people that work at a workstation that sit for too long. If you sit for hours at a time at a workstation, I understand it's your job to do that, but that's also can contribute to that impingement that you're feeling. So past modalities first, then active care next, a lot of strengthening some areas around the hip as well as keeping that hip mobile too. So if you guys would like to see a part 2 video of all those things of how we treat this, just let us know and we will be glad to make another video with that. But that's going to be it for today. Thanks for watching and we will see you next time.